Well, good evening, friends, and welcome to this October edition of Glaucoma Australia's live Q&A, proudly brought to you by our long-standing and very generous supporters at Glaucos. My name is Adam Check, and I am honoured to be leading Glaucoma Australia as its Chief Executive. And before I introduce you to our guest speaker this evening, I would like to take a moment to acknowledge the traditional custodians of the lands, the skies and the seas in which we collectively gather tonight. I'm currently on Darug country, and so I pay my respects to elders past and present, along with their emerging leaders. Tonight's Q&A topic is an important and often overlooked topic, pregnancy and glaucoma, and it will be presented by one of Glaucoma Australia's closest friends, Dr Noor Ali. Dr Ali is a fellow of the Royal Australian and New Zealand College of Ophthalmologists, completing her medical degree from the University of Auckland, New Zealand, before undertaking subspecialty training at the very prestigious Sydney Eye Hospital and the world-renowned Oxford Eye Hospital in the United Kingdom. Dr Ali is highly experienced in managing all aspects of glaucoma, including in clinic lasers and eye drops. Dr Ali also worked at Imperial College Western Eye Hospital in London and learned the latest techniques in glaucoma surgery and in theatre lasers to provide her patients with the opportunity to receive the best that modern care has to offer. Delighted to introduce Dr. Ali. Dr. Ali, the floor is all yours.
Hello, and thank you very much, Adam, and thank you everyone for tuning in with us to discuss this really important topic of pregnancy and glaucoma. And as Adam alluded to earlier, it's not something we think about frequently, and I'll go into a little bit why that is in just a moment. So a little bit about me, I'm a glaucoma subspecialist. I've also a uveitis subspecialist, and it's quite interesting because a lot of the glaucomas that tend to occur in pregnancy may actually be related to secondary issues such as inflammation in the eye, and we'll talk about that a bit later on. So this is the outline of the talk. In the start, we'll just discuss some of the changes in the eye, the normal changes that happen with pregnancy, the effect of pregnancy on glaucoma if it's present, and glaucoma treatments, including drops, lasers, and surgery during pregnancy and what they will mean, the risks and benefits of each one. And then we'll briefly touch on glaucoma and management after delivery. So, ocular changes, what happens to our eyes when we're pregnant? Well, the main changes that can occur are hormonal changes, namely progesterone, can actually reduce the pressure in the eye. This reduction is really small, it only tends to be 2 to 3 millimeters mercury, but there are some studies that have shown that in the third trimester, this change can be a little more profound, up to 10%. Now, keep in mind that these were described in normal people, so normal humans who don't have glaucoma. When they've been studied, this is what we've found. And this can be due to a number of reasons. One of the reasons is because we have an increased blood volume, and this could alter the fluid dynamics in the eye. And there are also some other temporary vision changes and water retention in the ocular structures, but it's also the resistance to the outflow is reduced. So that's why the pressure lowers. Now, a lot of patients may develop problems with high blood pressure, preeclampsia during pregnancy, and may get very concerned because the thought is often that if you have high blood pressure, it might be linked to high pressure in the eyes. But this is just fortunately not true. And the reason is the pressure in the eyes is a tightly regulated process of the body secreting the fluid, which is out of line, or it's completely different checks and balances than the blood pressure. So yes, it may have a teeny-weeny effect, but in general, if you have high blood pressure, it doesn't mean that your intraocular pressure will go up. So primary open-angle glaucoma, this is the most common glaucoma in our community, but it's a glaucoma of older people. So the prevalence of open-angle glaucoma in pregnancy in populations that are comparable to Australia is in the order of 1 in 1,000, maybe a little bit less, maybe a little bit more. So overall, thankfully, the standard glaucoma is rare. Most glaucoma in pregnancy is therefore due to other problems. So it could be a childhood type of glaucoma that was diagnosed because of a birth-related change in the eye. So, the patient was born with an eye that's not 100% normal and they have glaucoma secondarily. or a condition called juvenile open-angle glaucoma, which is defined as glaucoma which is diagnosed under the age of 40. Typically, these patients have a strong family history, and the reason they've come to us is, their mum or their nan or their uncle or aunt have glaucoma, and they've advised them to get checked regularly. And so these patients, because we have diagnosed them earlier, and generally we know that they need a little bit more help, a little bit more treatment. And finally, as discussed earlier, secondary glaucomas related to uveitis, which is inflammation in the eye, poorly controlled diabetes, and in this case it would be type 1 diabetes that would have had time to cause a problem such as glaucoma in that time frame, or trauma, like a previous injury to the eye, can also cause glaucoma in that eye. So all of the above conditions I've discussed are known to be a little more difficult to treat. They don't respond to the standard treatments that we give. So therefore, in patients with glaucoma, these types of glaucomas who become pregnant, the pressure could go up, could go down, or stay the same. So the rule doesn't apply like the normal patients where, a normal person gets pregnant and the pressure might go down a little bit. So we can always hope. So planning for treatment, it is absolutely crucial to plan, and the planning starts before you even start thinking about conception. The reason is during pregnancy, for the reasons discussed in the slide prior, we need more frequent reviews, more changes in treatment, and changes may be required each trimester, even small changes leading up to the birth. And not only that, we need to coordinate with your general practitioner and obstetrician to make sure that you and your baby are both safe. So the moral of the story is to speak to your ophthalmologist before you plan to get pregnant, if possible. Not always possible. Sometimes we're surprised, but where possible, speak to them. If you find out you're pregnant and you're on glaucoma treatment, notify your ophthalmologist immediately. So your ophthalmologist will advise you when to book reviews and create a plan to manage your pressure. In the big scheme of things, again, fortunately, glaucoma is one of these things where we treat over many, many years, and it progresses over slow periods of time. So a 9-month period, hopefully we can, maneuver and tweak the treatment of most patients to keep you safe, keep your eyes safe, and keep your baby safe. So typically what would happen is we may change to a safe medication before conception starts, and that'll take you through to the first trimester, and then check the effect 6 weeks after starting the medication, and then 6 weeks after you actually conceive. And then we would see you again in the second and third trimester and change the drops accordingly. And I'll go into that a little bit more as the talk goes on. So glaucoma treatments of pregnancy. So going back to the facts where we talked about that glaucoma is quite rare in pregnancy, and it can happen in these other causes for glaucoma, which are even more rare themselves. So therefore, it's really difficult to conduct large studies on the safety of glaucoma eye drops. And we have to extrapolate from either small studies or animal studies to arrive at our conclusions. There's also sort of the collegial body of doctors, and we all talk to each other and say, oh yeah, I had a patient who had this once, and I had a patient who had this. So there's a lot of collective knowledge and shall we say clinical experience with using these drops in glaucoma, but it's just not as well defined in terms of safety as in other situations. So option one, and the easiest one really, and I speak to a lot of my patients about this, is going back to the fact that if your glaucoma is mild and slow, so you don't really have much visual field changes, the nerve is not very thin, then we can say, well, there may not actually be meaningful progression in the next 9 months. If your pressure is not, super, super high, like 35 or 40, we may, if it's in the high 20s, depending on the condition, we may just have a conversation with you and agree that, hey, look, the chance of things getting worse in a meaningful way over a 9-month period is actually pretty low. And we can afford to come off the drops for 9 months, accept a slightly higher pressure for that time, and then restart them once you give birth, and and without you having any harm, and that way you haven't meaningfully gotten worse, you haven't exposed your baby to risk, and you haven't exposed yourself to stress and anxiety. So that is always a very good option, but obviously sometimes we're bound by each patient's condition and the details of each patient's condition. Option two, so we can avoid the drops altogether and do laser. So there's a laser called selective laser trabeculoplasty. This is a quick and painless in-clinic procedure. It's a low-powered laser, and it's directed precisely at the drainage system of the eye. And this means that it has a very favorable safety profile, and it doesn't affect the baby. It only affects that one part of the eye, the drainage system of the eye, because we place the lens on the eye, which focuses the laser directly on it. It's got a very favorable safety profile, the main risk being a transient rise in pressure. Now, again, if this happens, it's less than 1%, but we can afford to let that run its course because it only typically lasts for 3 days. Sometimes it's even safe to give a couple of tablets to manage that pressure, but again, because it's so short-lived and we know that it's going to be short-lived, it is a very reasonable option. The success rate of this laser in early glaucoma and standard open-angle glaucoma is 80%. So 8 out of 10 people have the desired effect. What is the desired effect, you say? It reduces the pressure by about 1/5 to 1/4, so 20 to 25%. Now, you may have had this type of laser before earlier in your glaucoma treatment, and it's fortunate that this is the type of laser that can be repeated. And it can be repeated a number of times, not just once. The limitation is every subsequent treatment has a slightly smaller size of the effect. So you may have had a fantastic response to it the first time, may have gotten 25 to 30% reduction in pressure. We can do it again a second time, but we may only observe 20% reduction or a little bit less than that. Still, nonetheless, as we were considering the situation before, if your pressure's not too high, we can even do laser, get the 20%, even if the pressure's not ideal. If your glaucoma is mild and slow, then we can live with it for the few months until you give birth. The downside is this glaucoma is not suitable for all types of, this laser is not suitable for all types of glaucoma. So you really need to discuss with your ophthalmologist to see if it's correct for you. In terms of anesthetic, we only need to use anesthetic eye drops, which are very, very safe to use in pregnancy because it's a one-off application. They're generally very safe, and it's got a very low risk of reaching the baby at the concentration that we give. So that is the other advantage of this, is no anesthetic risk. Option 3. So option 3, I've called this an individualized drop regimen for the duration of the pregnancy. And the reason I've said that is different people tolerate different drops. And not only that, the pregnant woman may have some pre-existing condition, for example, asthma or breathing problems, that may actually impede our use of some of the medicines that we have available. The aim is to make it individualized, maybe change it up a few times during the trimesters based on the risk profile of each medicine. And the absolute key is to try and minimize absorption. And this can be done depending on the available formulations we have in Australia. So for example, we can switch to drops that have a gel formulation, and these are more likely to hang about in the eye, less likely to be drained with the tears down the nose and absorbed by the small blood vessels in the nose, which take it to the rest of the body. Other things we can do, which I'm sure all of our glaucoma patients are familiar with, is punctal occlusion. And this is where you hold the corner of the eyelid where the little duct is that takes the tears to the nose for 2 minutes while the eyelid is closed. And that can significantly reduce the systemic absorption. A study recently came out that showed that simply dabbing the excess with a tissue with the eye closed can be as effective as punctal occlusion. In this case, I would say, why not do both? So dab with the tissue, dab the excess immediately after putting in the eye drop, and then do your punctal occlusion and eyelid closure for 2 minutes, and that should help. Okay, so let's go through the classes of medication. So I apologize for the long names, the medical names, but anybody who is concerned that I know of wants to know the class name and wants to go look it up. So I'll sort of give you the overview. Prostaglandin analogs are the first line treatment that we usually use for glaucoma. So that's for the likes of Xalatan or Travatan or Lumigan. So they're the number one medicine we reach for. And the reason is there's a large size of the effect. So this is a first line medicine in glaucoma treatment. So you may actually already be on this and therefore need to come off it. So prostaglandin analogs are category C in pregnancy, and which means that there's in animal studies, there is a suggestion that it can cause birth defects. In particular, we know that in animal studies, there is a high incidence of miscarriage, particularly in the first trimester. So when used in the first trimester, developmental defects, obviously, because that's when the baby's first developing, or spontaneous miscarriages. So we really want to avoid this as, in the first trimester. Secondarily, in theory, they can cause uterine contractions. And the reason we know this is a local prostaglandin analog can sometimes be used to stimulate contractions, and that's how we know that this is what it does. However, that's used in higher doses and right at the cervix, close to the opening of the uterus, and so it's really not that comparable to an eye drop used in the eye. So we call this a theoretical risk. There's a theoretical risk of stimulating contractions and so causing premature labor. And of course, we'd never use this in the first trimester, so second or third trimester, this becomes notable. So beta blockers, second-line medication under usual circumstances. This is what I was saying before, that if some ladies have breathing problems or asthma, then they may not be they may not be candidates for this medication in the first place, but generally it's a very well tolerated drop, very effective. Again, it's class C in pregnancy, which means it has the potential to cause birth defects. However, in animal studies, this hasn't really been proven. We do know, however, is that it can cross the placenta and slow down the baby's heart rate and also cause heart rhythm changes. I've had a couple of patients who we've started on this medication, and the patients have done very, very well. And it's as easy as writing to the obstetrician and saying, Mrs. So-and-so is going to be placed on beta blockers for her glaucoma. We have given the lowest dose possible with the lowest number of drops or doses per day possible, and we've advised her to do the punctal occlusion, wipe off the excess, hold the punctal occlusion for 2 minutes, but we still need some monitoring. So I've had a patient like this where the obstetrician kindly organized monitoring from trimester 2 to trimester 3, and the baby just had more regular fetal heart scans and looking at the baby's heart rhythm. And my patient gave birth safely to a lovely, healthy baby boy, and we managed her glaucoma during her pregnancy. Alpha agonist, the third class. So this, you may not have been on this drop or heard of this drop, and the reason is it's the third line or fourth line medicine that we use because the size of the effect is small compared to the other medicines. However, this is a category B in pregnancy, which is better, safer, which means there's a theoretical risk of adverse effects, but no, very low risk of birth defects. So we have slightly larger studies for this. And brimonidine, which is a particular alpha agonist, has been proven to be quite safe in pregnancy and has not been shown to cause birth defects. It can, however, affect newborns. So brimonidine is a drop that can slow down the respiratory drive, so the part of the brain that tells the body to continue to breathe. And so we really need to stop this before labor or before a planned delivery. So for my patients who are on this treatment, I would write it out in their plan when they first see me and say, we're going to be using brimonidine for the duration of the pregnancy, but we need to stop this at 6 weeks before term or before scheduled delivery, if delivery is scheduled earlier. And the patient gets that letter, they have it with them, and the obstetrician gets a copy, so if there's any changes in the birth plan, that can be instated. But so alpha agonists or brimonidine is the main medication in this category. They are the safest category in pregnancy. So this is the one that we would be starting everybody on in the preconception phase through trimesters 1 and 2 and most of trimester 3. And finally, the fourth category, carbonic anhydrase inhibitors. So again, these are class C in pregnancy, sorry, that should read brinzolamide. So rarely we have low fetal birth weights, and brinzolamide, not brimonidine, has actually been shown to be fairly safe in animal studies, whereas dorzolamide, which is also known as Trusot, can cause birth defects in animal studies. So it's not preferred. So brinzolamide if we need to use it. Another category of carbonic anhydrase inhibitors is a drug called Diamox. This drug is in tablet form. It is what we call a diuretic, so basically makes you pee out excess fluid. And it has been proven to be relatively safe during pregnancy. And we know this from patients that have other conditions, for example, excess fluid on the brain, and they haven't been able to have surgery for a condition like that during pregnancy. So patients have been given Diamox, and they've been given at quite high doses because there's no other option in that setting, and it has proven to be fairly safe. If this is necessary, it will be done with close blood test monitoring, because we need to monitor the blood counts in the blood, and we also need to monitor the salts in the blood, particularly potassium, because it can deplete the potassium in the blood. So the next option, of course, is if we run out of medications, or obviously we can only use 1 or 2, as you saw, at our disposal during the pregnancy. And of course, your ophthalmologist will discuss every category with you and see if it meets your comfort level to use this particular medicine at this particular time. But if none of those are controlling the situation, or the risks to you in particular are unacceptable, then glaucoma surgery is another option. So there's minimally invasive standalone surgery. What does this mean? There are microscopic stents that go into the drainage system, and these microscopic stents can reduce the pressure by about 20%. Typically, in patients with standard glaucoma, we would put in these stents with an operation called cataract surgery, which is an operation to remove the milky lens in the eye and replace it with a clear artificial lens. Now, this usually happens in people who are 60 or older. So in a younger person who is of childbearing age, there is no need or no indication to do this procedure. And so we do the stent on its own. The actual risks associated with putting in these microscopic stents are very small. There's approximately 1 in 2,000 chance of a serious infection in the eye that can cause loss of vision, and a small risk of bleeding or inflammation in the front of the eye that settles down with eye drops. So really the risks are very, very low. The duration of the procedure, it only takes about 15 minutes, but the downside is it's only suitable in certain types of glaucoma, and again, it only buys us a 20% reduction in pressure. Not only that, it doesn't work in 100% of people. It achieves that reduction in only 3 out of 4 people, but hey, that's still 75%. That's still pretty good. When we do the procedure, we can do it under topical anesthetic. So these are these strong eye drops that we talked about, or injecting a small anesthetic inside the eye. And this carries a very, very small risk after the first trimester. There is a slightly more involved anesthetic where we anesthetize the whole eye by injecting the anesthetic around it rather than inside it. But again, there is a very small risk with that. It's still a very safe anesthetic to have. Now, when we're doing surgery during pregnancy, surgery is a slightly stressful event for the body. Even if the patient is relaxed and comfortable, there's always a risk of preterm labor, because the body recognizes stressors with a heightened awareness while we're pregnant. And the other thing to think about is we need to do special positioning during pregnancy. We need to have it well planned, have a chat to the anaesthetist about monitoring the baby during the pregnancy. But with a lot of good planning, if it comes to that, we can actually do something after the first trimester and make a small difference. Then we come to traditional or incisional glaucoma surgery. So traditional or incisional glaucoma surgery is more involved. It involves making cuts in the eye to form a drainage filter or bleb. And this can be with the use of an implant, such as with Prisoflow or a glaucoma drainage tube insertion, or without the implant, for example, with a classic gold standard procedure, trabeculectomy. So all of these procedures have to be performed without a key component that we usually use. So we use an anti-scarring medicine called mitomycin C. This is teratogenic, meaning it can cause birth defects. So we do not use this during pregnancy. The aim of using it during the surgery is to keep the bleb that we have formed open and functioning and draining, because bodies tend to heal, especially in lovely young patients. Like pregnant people, they have a very good healing response, and when the body recognizes a cut, they'll, all the systems go to try and heal that. So when we cannot use mitomycin C during pregnancy and an operation during that, it reduces the likelihood of success and reduces the longevity of the operation. But remember, the months are short in pregnancy, so therefore it may actually help us get through the hardest part of the glaucoma during that time and reduce the pressure significantly, completely come off the drops. And, if it fails after that, well, I guess so be it. We can accept that risk because at least it got us through this part while we were not able to use drops or other treatments. Topical anesthetic is not recommended for these procedures. They're more involved, so we have to do a formal local anesthetic, which is injected around the eye to keep the eye still, keep you from feeling anything, and keep you from seeing anything, of course. So local anesthetic, like I said last time, carries small risks after the first trimester. And again, there's always that risk of preterm labor because surgery is a stressor for the body. So glaucoma treatment after delivery, basically around the time of delivery, we just have to avoid prostaglandin analogs because they can induce preterm labor. So that's, again, the likes of latanoprost, travatan, and Lumigan, and Zalatan. And we have to avoid brimonidine or alpha agonists because, remember, they can depress the baby's ability to breathe, the drive to breathe. So those two we can't use. And if it's just a little bit before delivery, we can, stop those drops 4 weeks ahead. And again, we can maybe tolerate a high pressure for 4 weeks or use the ones that are safe, which is a beta blocker or a carbonic anhydrase inhibitor. After delivery, a carbonic anhydrase inhibitor or brinzolamide, those are the best choices. Azopt is the trade name for brinzolamide, and there's also Trusopt, which is dorzolamide. There's only very small amounts that get passed down in the milk, but these medications are very, very safe for newborns. And that brings us to the end of the talk. So we'd like to open this up to the floor and ask people to come forward, and maybe Adam has some questions for me that I can help answer, or some things that I can help shed light on.
Noor, I always have questions for you, but Dr. Ali, thank you for, as always, being so informative and beautifully articulate. It will resonate very much with our community and those online tonight. Two questions in particular that are coming around the chat, so if I can ask them and for your response. The first one is, can glaucoma be passed down genetically to my baby?
Yeah, so we know that glaucoma has a genetic component, and there is clustering in families. So it is not a direct inheritance. So it's not like I've got glaucoma, my baby definitely has glaucoma, like I've got dark hair, my baby will get dark hair. It's much more complicated than that. And there are multiple genes that are involved. And so we can't really say what your baby's risk of getting glaucoma is, but we know that patients who have one family member who has glaucoma have a 10-fold chance of getting glaucoma in their lifetime compared to any other person off the street. And typically what we recommend is that relatives of people with glaucoma, particularly children of people with glaucoma, get screened 10 years earlier than their relative was diagnosed. So if you're pregnant, you've got glaucoma, and let's say you're 35, we recommend that your son or daughter get screened from age 25 onwards. Now, obviously nowadays, having screening for glaucoma, having your pressure checked and all the special tests is very, very accessible through our lovely colleagues, the optometrists. And so you may choose to actually take your child earlier than that. So the answer is yes, there is definitely a strong genetic link. It is complicated. There are multiple genes involved, not a direct inheritance, but the general advice is that first-degree family members should be screened, and they should be screened annually from 10 years prior to their youngest diagnosed family member. And just touching on that actually is, if you yourself have had genetic testing for glaucoma, for example, we now have basically a beacon in Australian research, CNX Bio, which is a genetic test developed right here in Australia. You just swab your mouth, you send it to them, and they come up with a polygenic risk score. So they look for all the genes that cause glaucoma in you and see how many are positive or have the particular variant that can put you at risk, and give you a risk score which tells you, you're high risk for developing problems in your lifetime, or you're lower risk for developing problems in your lifetime. And that is something that's more accessible. And certainly if you've been positive for a lot of those things, then that's something that your children can have later down the line. Of course, the topic of genetic testing in children who kind of aren't at the age to consent for something like this, who may not develop glaucoma till later in life. That's a more complicated topic, but again, I would recommend you discuss genetic testing with your ophthalmologist for yourself, and that might indicate that when your child becomes of a consenting age, so 18 or over, they may choose to pursue that.
Okay, terrific. Thank you, Dr. Ali. A couple of other, it's great to see when our chat room is full of questions and interests. There's a question here from one of our community supporters. What are the best tests to perform during pregnancy to detect glaucoma?
Yeah, so fortunately, all the tests that detect glaucoma are non-invasive. So we can do all the tests. We can do a full comprehensive assessment to detect glaucoma without any fear. So I'll just go through some of the things that we do. Generally, when we first assess a patient for glaucoma, we collect 12 pieces of information. And so some of those are questions. So like, he's asking you whether somebody in your family has it, etc. And some of them are just measurements of the eye, like measuring the vision, measuring your intraocular pressure, and all methods of measuring intraocular pressure are safe and have no effect on the baby. So you can have as many and any type you like. One other measurement we take is looking at the thickness of the front of the eye to corroborate that with your pressure, because the thickness can play into it and artificially bring it up or artificially bring it down. The measurement of the pressure, looking at the drainage system. So we place a small contact lens on the eye and look at the drainage system called the trabecular meshwork through that contact lens. We check the pupils, we check color vision, we have a look at the nerve in the back of the eye, and some of our more traditional and important tests are something called OCT, which is a scan that uses light rays, so not x-rays or ultrasound or anything like that, uses light rays through the eye, and then the signals bounce back and create a picture of the nerve, show us how thick the nerve is compared to the normal population, and that can be very reassuring. And then we can do something called a visual field test. This is where you place your face in like a half circle dome. They call it the fishbowl of the patients, and you basically get a little clicker and you have to focus on a particular spot, and then you see little flashes of light in different parts of the vision, and you click the button when you can see it, and that tells us that your side vision is healthy. So in summary, you can perform all the necessary tests to detect glaucoma during pregnancy. It is not at all quizzical, and it will never be a head scratcher.
Thank you, Dr. Ali. And I think there's one more question here, and then for the rest of the questions with our community and with your good guidance, Dr. Ali, we will reply to those generally. But I was intrigued with a couple of the questions around alternative therapy. So we've had a few comments around alternative therapies such as vitamins and acupuncture, and whether what is your recommendation when it comes to alternative or natural therapies such as these?
So I think alternative therapies, the other name for them is complementary therapies. And the reason they're called complementary therapies is because they complement the traditional therapies. They are not a replacement. And I'll give you a perfect example. I always say to my patients, glaucoma is a plumbing problem. You've got fluid being produced in the eye and fluid being drained, and generally you have problems with the drainage system. So if you imagine your home, the place that you live in, you're running fluid all the time for all the uses in the home, but if the drainage system is affected, you need a plumber. Basically, you need a plumber to help get it out of the way. And you can do all sorts of things for your home that will make it feel better, like ventilation, trying to deodorize the drains and things like that, but it doesn't get rid of the main problem. So I would say if your doctor has said to you, your obstetrician has said to you that acupuncture is okay, it may be good for you to reduce stress, to reduce anxiety, but it's not a replacement for pressure lowering therapy. We simply have to lower the pressure. In terms of vitamins have a great role in nerve protection, and they have this role over longer periods of time. And the two main vitamins that come to mind are vitamin B3, that has been studied, as well as ginkgo biloba. And so ginkgo biloba and B3, both of them have been proven to have a neurosupportive effect to the optic nerve in glaucoma itself, but that's in glaucomas where the pressure's already controlled, it is also a complementary therapy. And then again, you'd have to speak to your obstetrician about the safety of taking ginkgo biloba and the safety of taking vitamin B3 in your particular condition, because all pregnancies are different. So I would say, if it's a therapy that is not going to affect the baby in the other way and will help you manage stress and anxiety, then go for it. But it is not a replacement for the traditional pressure-lowering therapy, because we've got to get the drainage system working. So we need our plan.
Terrific. Dr. Ali, you have been tremendously generous with your time and your insights as always, and I resonate with the community. For our community members who have also asked additional questions, we'll make sure that we provide a response to those via email and certainly on web chat. So we'll be in contact. But for now, Dr. Ali, on behalf of the glaucoma community, thank you very much for your presentation tonight. Very insightful. And to our community members, thank you very much for joining us at this live Q&A. We look forward to seeing you again very soon.
Thank you, Adam. It's my pleasure. And I wish everybody a good night and a safe journey through your glaucoma and pregnancy.
Thanks, Noor.